So what we'll do is, I think Amanda is going to start projecting up on the screens there some of the notes we took yesterday. We will sort of step through that, sort of line by line. They're not that long. And then after we do that, we'll ask people what's missing, what's not clear. We also have, I will be chiming in sometimes if we have comments coming in over the web, especially from some of the people who had to travel and couldn't be back yesterday. So what you see here projected on the screen is the agenda document we used yesterday with some of the questions, and you can see sort of typed added in there in sort of the reddish color, if that stands out to you, the notes that we took. So we start with that first topic: when can we rely on real world data? And the questions, as you can see, organized there. What questions characterize the utility of real-world data source, signal reliability before a study is performed? Starting with, and this was a point I made channeling the point that Andy sent along yesterday, starting with Rob's point, saying, we have to orient ourselves, saying that the current emperor of randomized trial data collection and data integrity often has no close. That there is a false sense of certainty about the way we do things now. The point that Andy made about different stages in the pathway, that there is, whether people present for care, whether a provider accurately recognizes a clinical phenomenon, the things about the electronic health record system that affect the recording of data, and then the technical issues that affect how data flow from various source record systems into some analytic database. Those are all sources of error and slippage and problems along the way, but they are different. And there are different ways we might, things we might be concerned about, in different ways we might assess potential problems. The idea about the variation in methods, who decides whether something is good enough, but the most important point that was made over and over again, I think, is transparency. That the assertion that this is a valid phenotype or this is a valid specification will not go very far. What you need to show your work. We need to think separately about the different aspects of what we're using data for, whether it's to identify a study population, to assess an exposure intervention, or eventually assess the outcome. Amanda, you can keep scrolling down. Some specific points about measuring exposure using real-world data, that we have different concerns about measuring exposure to orally administered medications, to facility-administered medications, and we may have different sources of error there. And then about outcomes, coming back to that point about real-world providers being able to accurately assess clinical states of interest, and then points about how the recording process might change even in the course of a study, changes in coding systems that sometimes might be transparent and sometimes might be invisible. The point about, in the real world, the idea that there is a once and for all definitive diagnosis that's recorded at one point in time may not really happen. Diagnostic impressions may change over time, and how do you reflect that? How do you, in some ways, you could say that improves accuracy to say we have some, continuous reassessment, but it becomes less sort of specific or than it might be in a traditional clinical trial. Asking about safety issues and how we might use real-world data, the point being that there are sort of differences in products that are new and products that are well established in terms of what adverse events might be noted or recorded. The questions about the kinds of biases that can be created. One really important point that came up was the old saw that random misclassification biases toward the null we need to be careful there, because in a non-inferiority design, random misclassification biases toward a finding of effectiveness or a finding of no difference. And random misclassification may miss safety events that we would want to see. So I don't know how we would want to use the term conservative, but at least the way I would use it, random misclassification is not always conservative. It sometimes can lead to conclusions that would damage the public's health or be unsafe. In terms of expert adjudication, we talked about the idea that adjudication might be useful in some circumstances and not in others. There might be some time where an expert going back to look at some of the source data could actually improve quality. There might be times when the source data are lost. There's simply no way to know more than than what's the signal in the electronic health record. The idea of sort of continuous, that last point, I sort of expand that to say the sort of continuous monitoring of this sort of expected data flows, that over the course of a study, if we observe big departures from expectation, those are more likely to be errors than they are the truth. And I think we may be at the end of our part one. Is that right? Yeah, okay, so that's the end of our part one. So I know it may be hard for you to see all of those, but what we should do is now sort of take a step back, and those of you who were here for the discussion yesterday, in terms of we're saying right now in the real world data, that, issues about data quality, data integrity, how we assess that.